disorders. Welcome, Dr. Henderson. You can see us all. We're in a hall in London. We've got about 60 people here today who some have myotonic, some are family members, and a smaller group are staff of Muscular Dystrophy Queensland. So welcome and thank you.
Thank you very much, Penelope, and I hope you can all hear me. Thank you very much for the invitation. I've been a very big fan of the Muscular Dystrophy Queensland. Many of the patients that I see across a range of conditions are supported by Muscular Dystrophy Queensland, so it's a pleasure to be able to talk to you today. The myotonic dystrophy falls into muscular dystrophy, and it's probably the most common of the muscular dystrophies. It's a very broad area, muscular dystrophy, and it includes disorders that cause muscle weakness and muscle loss of function. And what it makes it a myotonic dystrophy is the characteristic of the muscle relaxation, and a finding that was originally used for on EMG testing, where you would have this very characteristic sound called myotonia. And practically for people, that would mean muscle relaxation or muscle stiffness would be the symptom that people notice. And so myotonic dystrophy is by far the most common of the myotonic disorders, but it's not the only one. And there are other disorders that have got myotonia, and the broad group is called channelopathies. And some of those have a few treatment options, and I can go through that a little bit more if there are people there who are interested in that. I'm imagining that most people will have myotonic dystrophy type 1, and it's also called dystrophia myotonica type 1. And some people might have myotonic dystrophy type 2 or DM2. And so those have got a very distinctly different genetic background. So people with myotonic dystrophy type 1, the problem is in this gene called DMPK, and it's a muscle protein kinase, so it helps muscle function. And the problem is too many repeats in that gene. So most people have got less than 35 repeats of that gene, and myotonic dystrophy, it's more than 50. And in between 35 to 50, most people don't have symptoms. And then the number of repeat expansions can be much larger. So anything up from 50 to 5,000. And there's a loose correlation about the number of repeats and how involved things are in terms of muscle strength testing. So, myotonic dystrophy in that DMPK gene is a repeat expansion. And I guess the reason I want to stress that is that other repeat expansions are a source of clinical trials at the moment. And the one I'm passionate about is motor neuron disease. And so the commonest gene involved in motor neuron disease is one which is given a long name, and that's because they don't really understand the function of the gene. So C9 or ORF72. And that gene has a number of clinical trials that are occurring for it in terms of repeat expansions. And I think probably the only reason myotonic dystrophy hasn't reached that same level of clinical trials is because the MND is regarded as a rapidly lethal disease within 2 to 3 years. But I reckon gene therapies are coming for myotonic dystrophy. So the problem in general is that the RNA that's produced by that gene is thought to be toxic. but there's still a lot of research that's needed to be known about actually what effects are happening, because, you know, as people there in the room will know, that it affects many different organs in many different ways. And the myotonic dystrophy type 2 is much less common, and it's in a gene called zinc finger 9. So it's on a totally different chromosome, but it causes a similar pattern, but usually less severe. And certainly the weakness is less severe. These days, the gene testing for myotonic dystrophies is very straightforward, and it's a blood test. And for example, Pathology Queensland could perform that blood test on anyone as long as they think of doing the gene test. The myotonic dystrophy type 2, most doctors won't know about, and most doctors won't know that they can also do that test through Pathology Queensland. And there's a little bit of a trap at the moment in that the where testing has gone to for many neuromuscular conditions is what's called gene panels. And the gene panels don't actually test for repeat expansion. So we talked about too many of the genes, and it's called a trinucleotide, which means 3 base pairs are expanded. And so they're not tested for in a basic gene panel. So it is an issue that people who are doing the test need to think of it. And look, most people who are doing the test do it because they're thinking of there's another family member who has had the testing. The test I don't think is particularly expensive through Pathology Queensland. And occasionally we see, and we'd see it at least once a year, that someone 70s, 80s might be having just a little bit of trouble swallowing problems, maybe a little bit of trouble breathing, and they're in hospital with a bit of a chest infection, and they're not improving as well as people think. And eventually the diagnosis of myotonic dystrophy is made. But those people have gone through life leading a very full and normal life, not thinking they had any trouble. On the other end of the spectrum, there are some children who have what's called congenital myotonia, and they're more severely affected in terms of weakness and maybe cognitive function as well. So the major manifestation is the inability to relax the muscles and muscle weakness. There can be other manifestations, you know, an earlier trouble with cataracts, some trouble with high risk of constipation, and perhaps abdominal bloating. And there's a very characteristic pattern of muscles that are involved. So many muscles are relatively normal, but some that are affected particularly is the muscles between the knee and the ankle, the muscles of the thigh, some of the muscles up in the upper arm, and there is a little bit of weakness in the function of the diaphragm. But for many people, that's not a major issue. For some people, that's important because if they're having fatigue, you can really try to chase down, is the problem in terms of people's ability to use their diaphragm, or is the problem coming more centrally? And I guess that's very relevant because there are therapies that would be targeted in different ways. So people there might be aware of a drug called modafinil, and there's a newer drug that sleep specialists use that target trying to activate the part of the brainstem that is contributing to apnea. Or the problem could be that use of interventions such as BiPAP would help people sleep better at night and have more energy during the day. So a respiratory physician is one of those people who, if we're thinking that most people should be part of a multidisciplinary care, a respiratory physician is usually one of the key people in there. And so there's a range of people in Brisbane who have taken an interest in that area. The second area that is important to consider is involvement of the heart. Probably 50% or less will have any issues there, but it's a higher risk of cardiac arrhythmia and the function of the heart. And why that's relevant is there's interventions for both. The ultimate intervention for an arrhythmia is to use a pacemaker or defibrillator, but there is mechanisms to try to increase the muscle contractility as well. So again, there is cardiologists who are taking an interest in myotonic dystrophy. And people in the audience are probably aware that Queensland Health that Brisbane River is quite large in terms of where services are and how services are coordinated. So, Metro South versus Metro North has some differences, but both Metro South, Metro North and Gold Coast and Sunshine Coast have got dedicated neurologists, respiratory physicians and cardiologists involved. And then similarly, privately, there are people who are taking an interest in this area. I'd also point out that there are other people who can be important. So, for example, people who are having gastrointestinal problems, a good gastroenterologist, and there's a couple of people in Brisbane who are taking an interest in this area. Some people who have a degree of facial weakness and not closing their eyes properly. There are people who specialise in that area of what's called oculoplastics who can be helpful. So once again, it's all part of a multidisciplinary team. That's really what's important. And that involves both hospital-based and linking with the community. And in that score, the involvement of all of the allied health services are important. So, physiotherapists, exercise physiologists in terms of muscle function, equipment, falls prevention, OT about use of the hands and, functioning in the home. Speech pathologists, I didn't include swallowing difficulties, but again, those gastroenterologists who take an interest would be helpful from that viewpoint of swallowing difficulties. So a good speech pathologist is part of a team. Dietitians can be important, particularly if people are having weight loss, and psychologists and social workers can be important. And so those people can be part of a multidisciplinary team in the hospital, but what is becoming better established in Brisbane and to a lesser extent outside Brisbane is support in the community. And so Muscular Dystrophy Queensland is a very clear person for that. And I guess about 15 years ago, when I started to get interested in this area, I became aware that Muscular Dystrophy Queensland was a good place that I could refer people to get advice on specialists. And then the NDIS came along, and the NDIS is a very generous funding package for people under the age of 65. And it's a good way to think of the funding to see therapists, equipment and home modifications. And again, organisations such as Muscular Dystrophy Queensland have been very helpful for people to get those plans working. So much so that I've been referring people with other problems with their nerves and muscle to Muscular Dystrophy Queensland. I get the feedback from all the patients that they're getting a great service, and I'm not quite getting a pushback yet from Muscular Dystrophy that I've overextended my referrals. But that's been a big success in recent years. Over the age of 65, My Aged Care and linking in with, again, through the services of Muscular Dystrophy Queensland and the services that Queensland Health provide. So north of the river, if you are seeing us with muscular dystrophy or any other condition, we'd be involving the complex chronic disease teams. So they're in North Brisbane, for example, they're based at Nunda and North Lakes. Metro South, I think, is better coordinated to try to provide that support directly into the community. So I might just digress then to just talk a little bit about, you know, the therapies and support, and then maybe just touch a little bit on research. So, I mean, we need a therapy. We need a therapy that can make a difference for muscle strength and muscle relaxation. There's been a couple of people where the drug maxillatine has been used to try to improve muscle contractility. Most people don't quite need it, and it does have issues with potential issues with the heart. So, and when people with myotonic dystrophy are already a little predisposed to cardiac arrhythmias, it's a good reason to be cautious with it. But it is part of a clinical trial that's occurring in the US. One or two people with more the channelopathy group of disorders, not directly myotonic dystrophy type 1, we'd try a drug called Diamox, very old drug, often reasonably well tolerated. So we need a better therapy for the actual problem of the muscles. So short of that, the care is saying that multidisciplinary team. So if we start at the top, thinking about how we can fix cataracts, thinking how we can improve and maintain swallow being at a safe level, thinking about the sleep apnea and thinking both centrally and a diaphragm, thinking about the heart function and the role of pacemakers in those drugs. And then the involvement of all of the therapists. I should point out falls prevention is something that we often forget to talk to people about. And again, women who are over the age of 50, 55, so postmenopausal, that risk of osteoporosis. So trying to prevent bone loss can sometimes be important to try to prevent fractures. So the care is what we'd call supportive. I had to do a bit of research to look up where clinical trials are at. So as I said, the ultimate would be to have gene therapy trials, and they're not quite there yet, certainly not in Australia. There's the US probably have been leading the way. So the organization in the US is called MDA.org, and the MDA organization in the US had a real lift with the involvement of Jerry Lewis, the comedian, and they've been able to fund and put money into clinical trials. It's also true that in the US, there's probably a number of centers that have been able to dedicate research to myotonic dystrophy, whereas in Australia, you know, it perhaps is a little more forgotten. Always used to think motor neurone disease was the forgotten disease, but myotonic dystrophy is probably even more so. There is clinical trials occurring, and I looked up and saw that the AOC 1001 DYNE-101 nucleic acid-based therapies, and that in the US in phase 3 clinical studies are drugs called tideglusibib and metformin and maxillatine. So if I digress to talk a little bit about clinical trials, so clinical trials have different phases, and that's why it's so frustrating for patients that it just seems to take forever for a therapy to actually reach you to be able to be used, or for you to say, can I be enrolled in a clinical trial that might work and actually help my function? So most clinical trials start off at the phase 1 level, and that's really trying to say, first of all, is the drug safe, and have we got the dose right? And even before that step is, can the drug be used in humans? So if you look at those drugs, tideclosamide, metformin and mexiletine, they've been tried in other diseases, metformin in diabetes, for example. So they've been shown to be safe in humans. So that's why those drugs get a big start. Whereas if you've got to prove a drug is safe in humans, you've got to start right back at an animal model, small animal model, go up to a big animal model like a sheep or monkey, and then you're able to do trials in humans. And then phase 2 studies, initial effort with the drug that, or 1 or 2 drug doses, and you're trying to prove in a smaller group of subjects that there is some evidence for efficacy, to then go on and fund a bigger phase 3 study. And phase 4 studies, the drug when it's being used in the community. So drugs for rare diseases, the phase 2 and phase 3 usually get overlapped. Obviously, if someone's on a real winner with a drug, it very occasionally jumps straight, and you know, they're called N=1 studies, but they're very rare in the area of the neuromuscular diseases. So most studies for myotonic dystrophy haven't been able to get to that phase 2 and phase 3. And, you know, it's probably been true for many of the other diseases affecting nerve and muscle, that they haven't quite got there. So most of the research is trying to better understand how the abnormal protein works and how it's trying to damage nerve cells. But, you know, the key is that research takes funding, and, you know, really what you're doing is funding the smart people to come up with the mechanism. People are doing it as part of research where you get young people doing PhD projects to try to take it to a level where it can be translated. It's usually not an area that you've got big drug companies, so most people sort of have to apply for grants, and the difficulty is that most of the big government grants are very much focused on more common diseases, heart disease, dementia, cancer. So it's been very hard for nerve and muscle diseases to get funding, and you've been relying on organisations, and Muscular Dystrophy Queensland might have a track record of that, but people in Australia who are interested can apply to the funding from MDA.org, the national body in the US. So perhaps another disease where there's some clinical trials happening is Duchenne's muscular dystrophy. Again, they're largely in the US, but there's quite a good hint that those clinical trials are coming and will be able to be used in Australia. So what we've been trying to do at Royal Brisbane and across the University of Queensland, QUT, and also at the Wesley Hospital is try to set up a framework where we can have clinical trials that are used for these diseases. So a nice example would be that one of the limb-girdle muscular dystrophies, and in all intents and purposes, this limb-girdle muscular dystrophy type 2I would look a lot like people with myotonic dystrophy, but that one, someone in the US has said, we've got a function for that, we've got a potential treatment, and we're saying, well, we've got a number of people in Queensland and we're in a position to do a clinical trial. So we're very much hopeful that before the end of this year, we'll be enrolling people in a clinical trial. And so, you know, if we can get to that stage with myotonic dystrophy, that's clearly the hope. I might stop there and see if people want to ask specific questions. I hope I haven't confused you or bored you. Everyone in the audience still looks like they're attentive. It's probably an older audience than a younger audience, because if I was giving this to medical students, I can usually tell because they've got their iPhones out and be looking at their iPhones, and I can't see any. So yeah, it's nice to see a good audience there. So thank you very much, Penelope.
Thank you. Yes, no iPhone down here. I think everybody has been listening to every word. So thank you. We're going to try and take a few questions. We'll see how we'll do this. We've got a microphone here, which we can take to people, or else they can come up. Has anybody got a question that they would like to ask?
Muscles, when it comes to relaxing, so my legs up and have to the shoulder away. Little problem.
Were you able to hear that?
No, if you could repeat it, that'd be good. There's a builder next door, so that's the trouble.
Oh, the builder next door. So, this gentleman is saying that he had changes with his muscles and his hands are tight. And he gets those things. Is this something that's common in myotonic dystrophy?
Yeah, so it tightness in the muscles, and particularly the hand muscles, is quite common. And probably one of the most common features. So it's the inability to relax the muscles. And people, when they've got that more severely, might be the people where we might try a medication. We'd be a little bit cautious about those medications because of the side effects, but if it's severe. The other people who can be a bit helpful are occupational therapists and hand therapists, and some people find that they'd use hand splints.
We tried that, but it didn't help.
Yeah, I mean, I can see, you know, that's a frustrating part of having myotonic dystrophy, is that tightness and the limitation in your hands. So it is a tricky symptom, I know.
Thank you. We've got another question here. I was wondering, can the triplets increase as you age? Were you able to hear that?
No, I wasn't able to quite catch that.
When your triplets those diagnosed 400, can they increase as you age?
Again, can you repeat it, Penelope? Or?
Yeah, sure. The triplets, can they increase as you age? When you were diagnosed, you were 400, and now you can increase. Wondering if they will do or can do.
Well, I heard something about aging. It's a tough, with any disease, there's an interaction between aging and the changes, and some of it is what people are doing research into, is what's called somatic mosaicism, and changes in your cell with aging, as opposed to just the aging process. But it is a reason why the disease becomes apparent with increasing age, whereas many people wouldn't have noticed the symptoms at a younger age. So, you know, a nice example where, you know, therapies are starting to make a difference in gene therapies is in a childhood disorder called spinal muscular atrophy. And if the gene therapies are started when a patient's a child, they can actually stabilize and people can have a normal development. But it gets a bit tougher when you're aging, and some of the effects on muscle have become established and to some extent aren't reversible. But muscle function can improve. You only need to think of going to the gym, you know, you can, and the ability of exercises to actually have a slight improvement in muscle function, whether you're normal, whether you've got myotonic dystrophy, whether you've got motor neuron disease. So some reversibility in muscle function or improvement in muscle function can occur, but you're battling always the effect of aging.
Thank you. Let's do one last question.
This is a question from England, actually. Anne's family in England, a number of them have DM2 and they have blood clots. This particular cousin I'm talking about has been diagnosed with low protein C in her blood, and so therefore a little anticoagulant. Those are her words. I hope that makes sense to you. Do you think this might have anything to do with DM2?
Yeah, so I mean that's the advantage of you know, being able to see if there is an overlap between diseases. You know, people with myotonic dystrophy might have other diseases just by chance. And off the top of my head, I would say that protein C or any other clotting problem would probably be unrelated, but I would say that that would make me put into a Google search protein C and myotonic dystrophy and just see what comes up. And you never know, sometimes there are associations, and there's been a number of diseases where the associated disease has actually given quite a big insight into the other disease. But you know, off the top of my head, I wouldn't have seen a direct association.
Thank you very much for your time. We appreciate that you have a very busy schedule and that you've taken the time to join us today. We've got a lot to think about. We appreciate the information that you've shared and the updates on the different research. So thank you very much. I think we're all very grateful for the time we've today. Thank you.
Thanks very much. Thank you all, and best of luck. I hope all is well. And if people do want to be involved with a multidisciplinary clinic, you know, I can reassure you that those clinics are out there. So we're at the Royal Brisbane and Women's Hospital as our primary base.
Thank you.
Best of luck.